Hello, everyone. My name is Hansel Ibarra, and I would like to welcome everyone to our Diabetes Continuum of Care, Improving Emergency Preparedness for Diabetes Management Learning Collab. Some housekeeping before we get started. To avoid background noise that could prevent some of you from hearing what is being said through the presentation, please go ahead and mute yourself, which should be right down at your left-hand side. If you have any questions, you can go ahead and scroll over to the Reactions tab and select Raise Hand. This will let us know that you have something to say. You may also use the chat box to type out your questions, comments, or concerns, and one of our faculty will let me know, or they will answer your questions through the chat box. When you decide to share, we encourage that you turn on your video. This makes the experience a little bit more personal. So about our Diabetes Learning Collaborative, diabetes affects more than 34 million people in the United States. Studies have shown that multi-tiered efforts to prevent, treat, and manage diabetes are critical in reducing the burden of diabetes, particularly for special and vulnerable populations. According to 2018 Uniform Data System, UDS, diabetes poses a unique challenge for HRSA Health Center programs because 1 out of 7 patients has diabetes, and nearly 1 out of those 3 has uncontrolled diabetes. In order to elevate the national conversation around diabetes, 14 national training and technical assistant partners, NTAPs, got together to form what is called the Special and Vulnerable Populations Task Force. The Special and Vulnerable Population Task Force looks to engage health centers, primary care associations, PCAs, and health center control networks to increase knowledge of effective strategies that address diabetes among people who are experiencing homelessness or residents of public housing, migratory and seasonal agriculture workers, school-aged children, older adults, Asian Americans, Native Hawaiians, and Pacific Islanders, LGBTQIA plus people, and other health center patients. This learning collaborative is sponsored by HRSA and will take a deeper dive into the issues related to the roles of enabling services staff, developing patient-centered resources, improving diabetes care and health equity, and management during a disaster in diabetes care and management. Here is a picture of all the 14 NTAPs that make up the Special and Vulnerable Populations Task Force. So today I am accompanied by Dr. Jose Leon. He is Chief Medical Officer at the National Center for Health and Public Housing. Myself, Hansel Ibarra, Health Strategy Specialist with MHP Salud. And we have Juliet Provost from NCECE. She will be stepping in for Ariel Mather. Ariel will be accompanying us in the remaining 3 sessions. So as a reminder, today is our first session out of 4 sessions that we're having throughout the month of March. We hope that you guys can go ahead and join us for all of those. The objectives for today, the first objective that we have here is we are going to understand the barriers to effective emergency preparedness for diabetes patients. We're going to go ahead and explore the role of enabling servicing staff in patient engagement related to ongoing diabetes self-management. And we're going to identify and implement best practices related to effective personalized diabetes care during emergencies. As a reminder, we have been doing some work on the diabetes front. To go ahead and look at the previous presentations and webinars that we have on this on diabetes, feel free to go into our website and you should be able to find there the different types of webinars and learning collaboratives that we've been hosting for the previous years. So before we get started, we like to do a little dinamica, an icebreaker, to get that jitters out of the way and help us feel more comfortable interacting amongst each other. So I'm going to go ahead and ask at this moment that you share with us your name, your title or role, the organization that you're from, and the special populations that you serve. And the question that you're going to be answering is, what are you hoping to get out of this learning collaborative? How does your work intersect with emergency preparedness? So as I mentioned, if you would like to, feel free to unmute yourself and you can share with us, or you could also type it on the chat box and we'll read it out loud. So let us know your name, your title, the organization you serve, the special populations that you also serve, and what are you hoping to get out of this learning collaborative, or how does your work intersect with emergency preparedness? Do we have any volunteers that want to share with us out loud? Or as I mentioned, you could also drop it on our chat box. Friendly reminder, we are trying to make this into an interactive presentation. So we do ask that you guys do participate whenever we have polls, questions, things of that sort. So we are trying to see what you guys are hoping to get out of this learning collaborative and how your work might intersect with emergency preparedness.
Good afternoon. My name is Marcel. I'm a CHW at Western Wayne Family Health Centers in Lincoln Park. I work with care management, and I hope to learn how to help my patient with the tools that you have to teach us today.
Thank you for sharing, Marcel. Does anybody else want to share? Do we have any on the chat box? Let us check. Quiet crowd today. All right, guys, so let's go ahead and move on, keep on moving. There we go, we got a chat box. If you can, we can go ahead and continue with the presentation. Feel free to drop it on the chat box. That way you guys can also interact amongst each other. Let me go ahead and read the one that we have here. We have Sandra, who's also a CHW from Delaware Valley Community Health, and she assists people with tools to control their diabetes. All right, let's keep on moving forward. At this moment, we're going to go ahead and launch a poll. This poll is in regards to our previous webinar, and we would like to know if you attended the webinar that we hosted on December of 2022. So it's a little quick poll. We're just trying to see if you guys before we offer our learning collaborative, first we conduct a national learning series. And we just want to see if you guys attended that presentation or if you hadn't. Right. So I believe we got some of those answers already. Okay. So thank you for participating in our poll. And it does seem that the majority of you guys did not attend our webinar. So hopefully this is new information that you guys can go ahead and take home with you and to assist your populations. So at this moment, we would have Dr. Jose Leon conduct his portion of the presentation. Take it away, Dr. Leon.
And good morning or good afternoon, depending on where you are in the country. I am very honored and very pleased to be part of this conversation. I know and I see some friends from different organizations. I see our friends from Puerto Rico PCA. Thank you, Francis, for being with us. So that we have people from Delaware, participants from other states. So thank you so much. It's such a great pleasure to see you all. And at the same time, I would like to talk a little bit, about the population that we serve, and specifically those living in public housing. This is a really special population because within public housing residents, you can see many chronic medical conditions affecting this population, and many of which are now here's a priority, specifically diabetes. The main topic that we are planning to discuss today has been priority for the Health Resources and Services Administration for the last 6 or 7 years, The idea is to reduce the number of people with uncontrolled diabetes, specifically those with A1C greater than 9. And this slide shows how public housing residents are more likely to have uncontrolled diabetes. When you compare them to other residents receiving some help from HUD or just the general population. In regards to diabetes, you see that HUD-assisted adults are almost twice, or they have diabetes at least 2 times higher than the other low-income renters or adults in the United States. And there are other chronic medical conditions linked to diabetes that those receiving assistance from HUD are more likely to have these conditions. Specifically, we know the link between obesity and diabetes, or the link of smoking and diabetes. Those who smoke are more likely to have diabetes. So these population have a lot of chronic medical conditions, and diabetes is the main concern, and not only for HRSA, but also for the United States Housing and Urban Development Agency. So HRSA and HUD have been working together for the last few years, making sure that all the great work that you guys are doing are received by the public housing residents and those living in or immediately accessible to public housing. So this is a really nice opportunity to talk a little bit about diabetes and emergency planning or on emergency management. We've been discussing, and I know that many of you have been participating in different sessions, specifically diabetes and how and the impact of social determinants of health on diabetes. We've been talking about diabetes and health literacy. We've been talking about diabetes and other chronic medical conditions. We've been talking about some complications such as kidney failure or the association between diabetes and heart diseases. So this is a really good opportunity to learn from you, because we are just moderating this session, but we would like to hear and we would like to learn from you what your experience is during emergencies. We have people from different states, and you face different emergencies. In Puerto Rico, for instance, we have some friends from Puerto Rico attending, and Puerto Rico has been struck by hurricanes, earthquakes, and all kind of natural disasters. We have people from California, and in California wildfires, and right now we have all these bad weather, and that you are not used to having a lot of rain, and we would like to hear if there is someone how this natural disaster or event has affected your patient with diabetes. So please feel free to share your experience, and everybody's learning here. We are learning from you guys, and we are leading this conversation, and it's going to be our pleasure to hear from all of you. Next slide, please. In regards to the populations that we serve, there are a couple of things that I always like to mention, because within public housing, within this special population, we have some vulnerable populations. And specifically, these are more vulnerable during disasters. And I'm going to start by mentioning the populations that we believe are more likely to be impacted by any natural disaster or any man-made disaster. If you see that in the middle of the slide, 38% of the households report to have at least one person with disability. and HOD doesn't specify the type of disabilities. So remember that we are not talking about physical disabilities, we're talking about any mental disability, Alzheimer's disease, any other condition. And these patients are more likely to have diabetes and more likely to suffer the consequences and the impact of natural disasters or man-made disasters. So let's make sure that if you are close to or immediately accessible to public housing, you have a plan. You have developed a plan to provide continuity of care to people with disabilities. The other population that is going to be impacted and are more likely to have diabetes are those who are over the age of 65, or our senior population. And 19% of those living in public housing are over the age of 65. So this is another population that we need to make sure that we help them during emergencies. And the other one is the children. 36% of households report to have a child under the age of 17. And somebody can say, oh, you know, but probably they are not affected by diabetes. Remember, we are talking about both diabetes, type 1 and type 2 diabetes. So let's keep that in mind and make sure that we always have a plan for those children who live in public housing and may have type 1 diabetes. And the other one that, in my opinion, we need to pause for a moment and think about how we can help them is those Latino population living in public housing. 26% of those living in public housing are Latino or Latinx. Sorry, I'm Latino. I am still not, I still don't like the Latinx concept, but that's my personal opinion. So the 26%, what is the problem with this population? The problem is that they may have some language barriers. So make sure that during emergencies, all your diabetic patients, if you have patient with diabetes, you develop materials in Spanish so they understand what is happening and how they can deal with their diabetes. So next slide, please. Our last challenge, or that is, well, it's still a challenge, is COVID-19. And COVID-19, the pandemic has shown many of the barriers that people are facing, or those with diabetes faced during the COVID-19 era. And if you see this slide, it's a recent study. It was done in 2021, and it's showing all the issues related to patients with diabetes and how what is happening not only in primary care, but what is happening in the community is affected or is affecting those with diabetes. And if you take a look at this slide, and keep in mind this slide, because for our next session, we are going to use this slide to see what the challenges are and how these challenges can affect those patients with diabetes, and how complications can derive or arise from any of these issues affecting our community health centers or community organizations. But mainly, the diabetes care has or was affected due to the lockdown of outpatient clinics, the decrease in patient capacity, the issues with staff shortage, medicine shortage, unaffordable medicine, delayed care seeking, limited self-care practice, transport difficulties, and undiagnosed case events. Remember that out there we have patients who are diabetic who are unaware of their condition, and an emergency can just increase the risk for them to develop any diabetes complications. So we are going to talk more next week about the challenges and how these challenges can affect those patients living with diabetes. So next slide, and I believe that I will have to turn it over to Hansel. No, there is one more, and this is something that our organization has put together. If you go to our website, NCHPH.org, you will find a couple of interesting things here. You will find the locations of all the 385 health centers located in or immediately accessible to public housing. You will find the locations of the public housing developments, and you will find different layers specifically showing the type of disasters that you can face based on the location of your health center. This is we gathered data from UDS, but also from the Environmental Protection Agency. They did this study showing what areas are most affected by hurricanes or earthquakes or other kind of natural disasters. So you can go to our website, and if you are in or immediately accessible to public housing, you will have the opportunity to see where the public housing developments are located and what type of disaster you need to prepare for. Next slide. So Hansel, take it away. And so you're muted. So it seems that Hansel is having some technical difficulties. Should we turn it over to you, Juliet, in the meantime, while we get Hansel back?
Sure. I'm just trying to think if it's possible for me to perhaps share my screen instead, so we can have the deck up. Okay.
What, are we in a room?
Yes.
I'm sorry.
Readmit console. Okay. So hello, everybody. Moving up a little bit in the timeline, but hopefully we will be able to go back and hear all the great content that Hansel has prepared for us all. So I just want to give a little bit of background and special considerations that we can put in place while thinking about older adults as we prepare for emergent situations. Let me just readjust my screen slightly so I can read everything that there is to be read and make sure that I don't miss out on anything essential. So first and foremost, the way that I want to frame this is just with the general knowledge that by the year 2060, it is estimated that nearly 1 in 4 Americans will be over the age of 65. As a result of that, older adults are consistently the fastest growing patient population served by our federally qualified health centers. To put this in a sort of numerical figure, older adult patients have experienced a growth rate of 170% over the past decade in our health centers. And perhaps on a more on the ground metric that might be more helpful to conceptualize, our center has personally estimated and identified approximately 400 federally qualified health center sites and lookalikes that have a patient population of over 15% aged 65 and older adults. We consistently see that number each year that we've been tracking it. We've been doing that for about 4 years now, go up by at least roughly at the lowest 10 sites to about, more realistically now as the population ages, 30 to 40 sites. So that's just one little piece of the puzzle, that older adults are growing into this population every single day, and we will continue to see that happen at a more accelerated pace. Additionally, in addition to being one of the fastest growing population groups, older adults are also an incredibly heterogeneous population, incredibly diverse in their intersecting identities, level of mobility, ability, and for the purpose of this collaborative, complex care needs. We know that 60% of older adults have 2 or more chronic conditions and are engaging in some type of disease management. Because of the varied care needs of older adults, treatment plans, level of intervention, and care needs all vary for the individual patients in your health center setting. But we do know that many community dwelling older adults rely on assistance through some sort of informal caregiving. And in some cases, an older adult patient is also a caregiver to a partner or family member themselves. So approximately 1 in 3 adults in the United States of America currently provides some sort of care to another adult as an informal caregiver. Older adults are no exception to this metric. The CDC currently reports that about 19% of adults aged 65 years and older are informal caregivers, having provided regular care or assistance to a friend, family member, or spouse who have a health problem or disability during the last 30 days. So that's just context in when we think about older adults, we need to think about their specific care, but also any care that they could be providing. So I'm gonna move to my next slide. Oh, that moved my script, not my slide. My apologies to everyone for any technical glitches. So special considerations for older adults. Let me just get back to what I thought I was looking at. In emergent situations, we have some, but not all of the special considerations that need to be made for when managing and responding to the unique needs of your older adult patients, and how their ability to effectively manage chronic conditions and crisis situations can be impacted by these factors. So the first that we wanted to highlight is disabilities related to mobility, visual, hearing, and/or cognitive impairments. Basically, how your patient is able to navigate the physical space they are inhabiting during any sort of crisis situation. Mobility, how are they able to move across the space? Are they using a mobility aid? And would being separated from their mobility aid during an earthquake or any other inclement weather, would that impact their ability to move around their home, to move around their community, to get to transportation, to even be able to evacuate? Will they have access to transportation that can accommodate a wheelchair, that can accommodate packing up a walker, these sort of things? And thinking more about visual, cognitive, and hearing impairments, how will your older adult patient be able to assess an emergent situation unfolding? Will they have the capacity to hear any sirens, alarms, alerts from their phone, et cetera, et cetera? Limited social networks. We know that older adults are at an increased risk for social isolation, and that older adults are at an increased risk for experiencing health complications due to social isolation. And then I touched on this briefly earlier, but access to transportation, the ability to connect with community services is therefore impacted if you don't have access to consistent transportation. The ability to collect any offered supplies or assistance can also be heavily impacted by the ability to access transportation, and then just in general, the ability to comply with evacuation orders. So those are all just things to keep in mind specifically when thinking about all patients, but in particular, good to keep in top of mind when thinking about older adults. So moving forward again to my next slide, hoping that my screen won't glitch out on me again, and hoping that you can all see everything as well. So to reduce risk of injury and acute illness and facilitate effective and efficient disease management care, particularly for diabetes during emergency situations, our priority to improve recovery outcomes is to fill one major gap, and that is emergency preparation planning conversations for older adults. So the one report that we found in the American Journal of Public Health, published around 2017, found that fewer than 25% of older adults have reported having an emergency plan in place of any type at all, and that roughly the same proportion of the population did not have access to a car, means of transportation, or other external resources if they were to need to evacuate because of natural disaster or inclement weather. So what can we do to fill these gaps in our health centers and improve recovery outcomes at the health center level? As I've alluded to, having ongoing, continuous, and open conversations with older adults and, if applicable, their caregivers and elected neighbors, support system, community members that they trust is the best way to provide them with tailored, easy to access information related to emergency and disaster preparedness guidance for your specific region and area, town. So these tailored recommendations should include information related to medications, specifically plans for accessing a 30-day supply of medication, the operation of any potential medical devices needed, and the backup power that would be needed provided power is cut off. Is there a backup power source? If they don't have a backup power source in their home, where is the most accessible, closest source of power that could help them reconnect to such a device? Mobility aids touched on earlier, but what happens if the patient is disconnected in any way, shape, or form from the mobility aid? What would be a backup plan for getting back to those treatments that are necessary for their ability to be independent, live in the community, and recover from such an event? I also want to shout out here that on this slide in particular, we have a resource guide from the American Red Cross, and on the previous slide, we have a resource guide from SAMHSA outlining specific and much more tailored recommendations for different regions of the country and how to engage with effectively and communicate with older adult patients, and local resources, charities, local government departments, all these things, how to make sure that all spheres of a care team are in alignment and able to communicate during any sort of emergent situation. I will put those in the chat when I am done. They're great resources, and we really do recommend that you take a look. So the second thing to keep in mind when helping consistently have updated and specifically tailored emergency plans for older adults is access to community-based disaster self-preparedness educational programs, emergency information developed and distributed by essential community-based services. We're shouting out Meals on Wheels on the slide, but there are many others. Specifically, internally, our recommendation would be to think about a few things when talking to your patients and when talking to your teams and your health centers about how you are approaching distributing these programs to your patients, one of which being for things like Meals on Wheels. Is there pre-enrollment available for your for your older adult patients? Internally, how do you plan to communicate local partnerships, local resources, recommendations from the government to your patients, and particularly for older adults, when crafting communication strategies, we recommend at least 1 to 3 varied channels of communication from a health center or community organization. You know, older adults, like all populations, have varying levels of technology access and media literacy. and technological literacy. So it is important to bring that message to people as many ways as you physically can, so everyone can access it regardless of broadband, phone accessibility, computer usage. And then internally, we recommend training in age-friendly care for interdisciplinary healthcare teams, more of which our specific recommendations can be found through the Red Cross Guide and through the SAMHSA Guide. So thank you for letting me move up a little bit, and hopefully we have Hansel back and he can speak to MHP Salud's work.
Yes, ma'am. Thank you for that. I apologize. Can everybody hear me?
Yes, we can hear you.
Okay.
Do you want to, I stopped sharing my screen, but would it be helpful if I shared my screen, Hansel?
Let me go ahead and see. I might stop sharing my camera. It seems that my internet is lagging. Let me see if I can share my screen myself. All right. So it seems that it's still lagging a little bit. So if you guys can still hear me, I can do my presentation. If you can just show my slides, I appreciate that.
Yes.
One more time, I apologize for everybody. New world problems right now. They're using technology. We have to deal with little things like that. There might be someone in my household using up my broadband. But I'll go ahead and continue this presentation like this.
Is this your first slide, Hansel? I just want to make sure.
It should say population Hispanic Latino communities.
Awesome.
My screen is also blank. I'm frozen and everything, but I'll continue like this. As I was saying, we have spoken about individuals who are experiencing homelessness or residents of public housing, and we've also spoken about individuals that are elderly. We will go into further detail for all of our populations in the remaining of the sessions. We are now going to turn our attention to the migrant seasonal agriculture community. This community is predominantly Hispanic. What does that mean, being Hispanic? Well, Hispanics are people who have ethnic or ancestral ties to Spanish-speaking countries or culture, typically in Latin America or Spain. The term Hispanic is often used in the United States to refer people with roots of Spanish-speaking countries or cultures, including Mexico at 61%, Cuba at 3%, Puerto Rico at 9%, Central and South America at 9 and 6%, and Spain, which would be at that 6%. The term can be used to describe people of any race or ethnicity who have ties to these countries or culture, although it is often used to refer to people who are of Latin America or Iberian descendants. It is important to note that while Hispanic individuals share some cultural and linguistic characteristics, they are a diverse group with a wide range of identities, experiences, and backgrounds. Next slide, please. So this map or this slide shows you a map of where the Hispanics tend to live. If you see here, the majority seems to be close to an area that is big in farming. So if you see the spread out of the Hispanics throughout the United States, you will notice that a majority of them are present in those farming communities, in those farming states. Next slide, please. So there are several common health risk factors that affect the Hispanic community. This include things such as chronic disease, which would be obesity. Hispanic individuals have higher rates compared to other racial and ethnic groups in the United States. This leads to an increase in diabetes, heart disease, and other chronic conditions. Speaking of diabetes, Hispanics also have a higher risk for developing diabetes compared to non-Hispanic whites. This can be due to either their genes or also lifestyle factors and their access to healthcare. We also have an increase or a higher rate of high blood pressure. Having high blood pressure leads us to the following risk factor here, which is kidney failure. You also have them dealing with cancer. And aside from all that, you also have environmental factors or working conditions. Hispanic communities may be disproportionately affected by environmental hazards such as air pollution or exposure to toxic substance, which can increase the risk of respiratory and other health problems. It is important to note that these risk factors can vary within the Hispanic community depending on factors such as country of origin, socioeconomic status, and acculturation levels. Next slide, please. Can you guys still hear me?
We can still hear you. You're
Okay, nice. All right. It's because you guys froze again. Anyways, continuing forward, managing your diabetes is already a difficult task. Emergencies, whether they are natural or man-caused, can make this even more difficult. There are several special considerations that providers and medical staff should take into account when working with the Hispanic community before, during, or after emergencies. These considerations include
So it seems that we lost Ansel again, and he is experiencing some internet issues. Our apologies for that.
Yes.
And but just to I don't know. I mean, this is how you need to prepare for an emergency. Have an emergency planning. So I'll take over the last slide that he has here, but he was talking about the special considerations that we need to have during emergencies. Specifically, if we are serving the Latino population, we've been talking about the language and the language barriers. Remember that many of the Hispanics living in the US are first generation, and he's coming back.
Sorry about that. I am back. Can you guys hear me?
Yeah, we can hear you.
You can.
All right. Okay. It seems that. All right. So let's go back to where I stayed. Hopefully this doesn't happen again. We were under. So I was mentioning how some special considerations that you have to have when dealing with the Hispanic community is a language. Sometimes we under the assumption that just because you translate some materials in Spanish, that every Hispanic individual is going to be able to understand this. As I mentioned, there are different dialects in the Spanish, as well as indigenous individuals that do not speak Spanish just because they're from Central America or Mexico. Another consideration that we need to have is the culture. In the Hispanic community, there is a distrust to Western medicine, and they tend to prefer natural remedies. So we need to consider that whenever we are offering resources to those individuals, not so much let them know that their remedies are not useful, but encourage them to include Western medicine along with their natural remedies. And also there's things such as familismo and fatalismo, which lead us to stigmas. Stigmas in this community also affect the type of healthcare that these individuals look for. I spoke about I mentioned familismo, and this is the belief that everybody is ahead of your own need. So individuals tend to put their family members, their children, even sometimes their friends above their own health, and they won't look for assistance because they feel that they are the stone in their family household, and they cannot get sick, right? And you also have fatalismo, which is the belief in destiny. Some individuals will say, hey, there's no need for me to go look out for services. Será lo que sea. Será lo que Dios quiera. It's going to be, it is what it is, right? So those little things affect, those are some special considerations that you have to keep in mind whenever you're dealing with the Hispanic community. Another is going to be their dietary needs. It is easy for someone to offer alternatives, healthier alternatives to some common foods, but we need to keep in mind that we need to offer things that this community might be familiar with, and not just the community itself, but the people that we are targeting. An example that I always use, I learned about tostones. If someone were to have offered me tostones before a few years back, instead of me eating tortillas, I would have been like, well, first of all, what are tostones and why are you offering me this? So there's some things that you have to go ahead and keep in mind whenever you are dealing with this community. They all have different types of dietary needs. So you want to make sure that whatever you offer is something that is available to them and that they have experience cooking it. Another is going to be medicine management. So these individuals, they sometimes tend to share medications amongst each other. So that's another thing that we have to go ahead and keep in mind when dealing with this population. And lastly, here I have lack of access to preventive services. So this could be either lack of health insurance, lack of knowledge of available services in the area. Maybe they don't have transportation, time constraints, income constraints. All of those are things that you must, or that one needs to keep in mind when we're dealing with this population, whether it's before an emergency, during an emergency, or after an emergency. Next slide, please. So community health workers, CHWs, can play a critical role in improving emergency preparedness for diabetes management in their communities before, during, and after emergencies. Here are some ways that the CHW, community health worker, can assist. They can provide diabetes education and make the community aware of what diabetes is. And this can be done in a culturally appropriate manner. They can go ahead and assist with creating emergency plans. As I mentioned, not only during emergencies, but they can go out before the emergency occurs and maybe after the emergency and offer some resources, point the individuals to where the best location would be for them to get some assistance. Speaking of looking for assistance, CHWs can also make referrals and resources available to them. They make resources that are being offered to the community. They make the individuals become aware of that. And they also assist with providing warm handoffs. Studies have shown that if when you present someone information and you do it in the warm handoff manner, which is where you let them know where they need to go, who they need to speak to, and what they're going to expect, they're more likely to utilize that assistance. In a CHW, because they are aware of what available resources are in the community, they can provide that information to the patients. Because I keep on saying that they're from the community, they know what the community struggles are, and they can advocate for resources for the community to overcome and address those needs that they have. And they also approach the individual through a holistic view. Instead of them just focusing on a patient's physical health or even a symptom, a whole person care looks at a patient's entire situation, including their emotional and mental health, their economic conditions, and their environment. So overall, enabling services staff play a vital role in supporting patient engagement related to ongoing diabetes self-management. They can help patients develop the skills, knowledge, and confidence to manage their diabetes effectively and achieve better health outcomes. By working collaboratively with patients, families, and healthcare providers, enabling services staff can help to create a patient-centered care approach that empowers patients to take an active role in their diabetes care. Next slide, please. And from here, we can go ahead and move on, skip over this. All right, so now we have a question that we would like to go ahead and pose to everyone, and we would we want to go ahead and hear from you guys. So what barriers do patients in your health center experience related to diabetes self-management? So at this moment, we're asking for anybody to either drop it on your chat box or feel free to come off of mute and let us know what are some of those barriers that your patients are currently experiencing. So as I said, we want to hear from you guys. We want to go ahead and hear what are some of those things that you guys are currently encountering, some of the challenges, some of those barriers. So what are some of those things that you guys have to work through?
Hansel, are you able to see the chat? We have portion control and access. Those two challenges.
And Hansel, also, Francis had commented earlier in Puerto Rico after Hurricane Maria, people had complications months after due to complications with no access to healthy food. So thinking about the barriers that people may experience related to diabetes self-management, so just typically may have access issues to healthy food, but in cases of natural disasters or public health emergencies, that becomes greatly compounded.
It becomes very difficult, especially if those individuals are taking insulin, right? If you don't have any power, it becomes difficult for you to keep that insulin cool.
And Francis also mentioned transportation, so just getting to the places that you need to get to.
And we'll be touching more on these barriers throughout the presentation. So this one is just to try to get to know our attendees, try to figure out what is it, some of those things that you guys are encountering. I see another one here, teenagers who are not on board with management, poor parent oversight.
If I may, Hansel,
Yes, sir.
Francis, you are bringing up a really good point that the complications cannot be just after the emergency, but it can be weeks or months after an emergency. And specifically, you are touching a really interesting point, because we know that how we manage diabetes is on two pillars, right? One is access to healthy food. The other one is a fitness or exercise. So I am assuming that when you're saying complications with no access to healthy food, probably you are talking to diabetic patients who develop hyperglycemia because of or due to the inaccessibility of healthy food, I guess. Is that what you're referring to, Francis? I'm sorry. Yes. Okay. Yeah, that's a really good point. Remember that when we are talking about diabetes, we have acute complications. It can be hypoglycemia, it can be hyperglycemia, but we also have some complications that we are going to discuss during our next session that can really cause an impact on the health of those with diabetes. But thank you all for sharing this information. This is very helpful. Thank you.
And I believe we can go ahead and move on to our next question. And the next question that we have here that we want to go ahead and hear from you guys is, what are you guys doing currently to communicate with your at-risk patients about these emergencies that are going on? What are you doing before the emergency happens? What are you guys doing during the emergency? What are you doing after that emergency? And do you utilize any enabling servicing staff to assist with these efforts? So we can break this question into two pieces. First is, what are you guys currently doing to assist with your at-risk patients? And then we can go ahead and discuss if you guys are currently utilizing enabling servicing staff to assist with this. Are you guys currently utilizing any enabling services staff? Or better yet, are you guys familiar with enabling servicing staff? Have you planned? Yes, having a plan is always important, right? You want to have something established. You want to have something that you guys can go ahead and turn to, and not just be caught off guard. So having a plan of things to do when those emergencies happen, it also allows your patients to react quicker, since they already know what to do in case of those emergencies.
So in the while we are waiting for additional responses, Hansel, one of the things that I've heard from health centers in or immediately accessible to public housing is that I mentioned before that we have people with disabilities living in public housing, people, seniors over the age of 65, children. They are more likely to have issues during an emergency. And what they have created is a type of registries, some type of registries based on what they take from the electronic health records. So they have a list of those living in public housing developments, and that they consider they are at risk. And they are the very first one that they reach out to when an emergency is coming. You know, either is something that they can plan in advance, like a hurricane. There are others like earthquakes, for instance, that you have little time or no time to plan. But it's always important to review your electronic health records, you know, and based on the information that you gather from your electronic health record, making sure that you reach out to your patients in advance. That's some of the things that we have discussed with the public housing primary care grantees and the public housing agencies. So the need to collaborate and make sure that they share this information.
Thank you for sharing with us, Jose. I guess we can go ahead and move on to our last question. Oh, we have an answer here. It says, it must be difficult to bring up emergencies with patients so as not to cause fear, but it is important to have a plan in place, as Francis mentioned. Yes, I agree with that. Thank you for sharing that. And the last question that we have here is, what emergency preparedness resources are available in your state or territory for patients living with or at risk of diabetes? So I see here that Francis also mentions that they stay open during those emergencies. So they are I would assume they are the beam of light in those hard times. They stay open. They say they have mobile units that they use to go around and to serve different areas. Nice. And as we wait for some of you guys' answers, we can go ahead and run the poll. We want to make sure that we capture you guys' evaluation before we end our presentation. So we can go ahead and run that, and I'll continue us through the slides. So as you guys are answering the poll, I'll continue here. So our next session is going to be happening on Tuesday, March the 14th, and it's going to be at the same time as the one today. For this session, we would discuss the challenges to provide diabetes management during emergencies, list the diabetes complications that are exacerbated during emergencies, and provide some diabetes actions to help patients with diabetes before emergencies. So one more time, I welcome you guys to join us next session, which is happening on the 14th. Feel free to share this link with other of your coworkers. The more individuals show up, the better. So if you've already signed up and you have the link and you want someone else from your organization to attend, feel free to share that link with them and they can go ahead and be part of our conversation. As I mentioned earlier, we are running that poll. The purpose of this poll is try to make sure that we are reaching those objectives that we proposed, and that you guys are taking some information and it's valuable to you guys. So I ask that you guys go ahead and complete that poll. Shouldn't take more than a couple of seconds. I believe it's only three questions long. So if you guys can go ahead and complete that. And next slide, please. And that should take us to the end of our presentation. So at this moment, we open up to any questions, comments, or concerns that you might have. If there's something that we didn't touch on or you would have liked for us to have touched on, our emails are on the screen. Feel free to reach out to us and we can go ahead and make an effort to put that information or include those pieces in our next sessions. As I mentioned earlier, this is the first session of 4. So we do expect to see, or we will be seeing you guys throughout the whole month of March. Are we staying on and having a debrief, or we want to do that later?
I believe we have one scheduled for Thursday morning.
Okay, nice. All right.
All right. So Thank you so much, everyone, for participating on this first session. We are going to discuss next week a couple of things about diabetes complications during emergencies and how we can plan in advance. So again, if you have any question, please send it to us. And it's been a pleasure, despite of the technical difficulties. We are very, very pleased to be with you and hear from you. Thank you so much. Everyone, have a great afternoon.